Okay, this is Paul Lynch. Day 3 of my experiences in New York City working in the ICU. That was a long day. I literally just got back to my hotel room. It's probably like 8 o'clock at night. Put in about 13 or 14 hours today. It's basically a war zone at this point. I wanted to tell you a little bit about Bellevue Hospital. For those that don't know, Bellevue was the first hospital in the United States, and we have a long history of dealing with epidemics, from the yellow fever in the 1700s to cholera in the 1800s, even the AIDS epidemic in the 1980s. Bellevue was kind of ground zero. It seems like we're doing that again. I think a lot of the transfers are coming into Bellevue. Bellevue historically treats anyone who wants to come, kind of like America and the Statue of Liberty. And so we get a lot of indigent populations, people without insurance. And so a lot of the sick are coming to us. I trained as a resident here. I started 18 years ago. And so I spent a little time talking to the residents today and what their experience has been like. And it was kind of scary for them. About 50% of the residents here have got COVID. 1 in 3 have a positive test, and then the other ones were just presumed sick because they got the same symptoms. But they think it's around 50% of the 70 residents have been infected. We did good work today. It was a long, hard, tough day. I was working on the airway team and probably responded to 10 codes, but I think everyone lived. Everyone that we saw, we were able to keep alive. Now, what we're learning is that this disease is much worse than we thought. And right now, we're estimating about 70% of the people that we intubate will end up dying later in the ICU. But today we did good work. We saw lots of people on the floors. There was lots of chaos. Sometimes 2 or 3 patients side by side that were intubating. And it was a really scary time. Lots of confusion and just all hands on deck, for sure. I wanted to teach you guys just a little bit. I wanted to leave every night with just a couple teaching points. So the first one, the state of New York released their data about who's dying and who's surviving and what the patient population looks like. And what's really clear from the data is there's a strong genetic component to this disease. And so based on the data out of New York City, which is almost 9,000 deaths at this point, so it's a really large it looks like if you are Hispanic American, you are 2.5 times more likely to die from this than a white American. And if you're African American, you're almost 2 times more likely to die. I read a lot today when we had some downtime early in the morning, even in some of the studies that have been done on drug trials. One trial pointed out that a mom and her son both were not responders, and they predicted a genetic component to this. And so I think you're going to hear more of this in the next couple of weeks. But as we look at which countries do well and which countries look poor or do poorly, part of it might have to do with health or pollution or response rate and all these other things. But I think we're going to start to hear a lot more about this being a genetic disease, which makes sense because it's an RNA virus that gets into the cell and takes over the cell basically, and it interacts with our DNA. And so how could it not have a genetic impact? The second point I want to make today is when I started my pain practice 12 or 13 years ago, we always talk about treating every patient like our own mom or dad. And what I've noticed in the last 3 days that I've been here is I'm really applying that to my practice here for the first time. And what I mean by that is when I was a resident, if I was called to a code to intubate, I wouldn't know the patient's name, only to write the note after. I wouldn't talk to them. I wouldn't interact with the patient. I think I just came to do my job, to intubate them and get out. And I think that was probably protective. I spent 4 years in New York City and saw so many traumas and so much death and dying, but I wasn't emotionally affected by it very often. I think in 4 years of being here, maybe I cried once or twice because of the death that I saw. But I'm treating it differently, and I think maybe I'm older or wiser or whatever. But now when I go to the code, I'm talking to the patients, I'm asking them where they're from, I'm learning about them, and I just think maybe maybe my reason to be here is to give them comfort as they're dying. I think in 4 years of being here before, I maybe cried once, and I've cried every day this week. But I think I'm helping them more than just the medications and just by intubating and just by giving them oxygen. I think just to hold their hand, just to hold their hand in a scary time for them is important. So my 2 points for today is that there's definitely a genetic component to this, and there's a human element too. And as we're treating the patients, we should allow ourselves to be personal with them because it's important to them. That's the end of day 3. Stay safe.